Okay, welcome to the deep dive. We're jumping straight into your notes today, specifically diving into Henoch-Schönlein Purpura, HSP.
Exactly.
Think of this as taking your revision material and really, unpacking it, pulling out the absolute essential high-yield insights so you get that clear, fast understanding.
That's precisely the mission. We're here to guide you through this topic, sticking strictly to the information you've gathered, making sure you grasp the core concepts for revision or just, well, to feel well informed. It can seem a bit complex, but the goal is clarity.
And right up front, we can tell you this condition. It's often recognized by a classic four-part presentation, usually called a Tetrad, and something you'll most commonly see in children.
So let's unpack that first key point from your notes then. What is Henoch-Schönlein Purpura? Okay, so your notes define it as a systemic vasculitis. Now, vasculitis just means inflammation of blood vessels. Simple enough. Systemic means it affects vessels throughout the body. But the crucial part of this definition, and this is really high yield, is that it involves immune complex deposition and inflammation specifically of small blood vessels. And what makes HSP unique, according to your notes, is that it's described as an IgA-mediated autoimmune hypersensitivity vasculitis. That mechanism, centering on IgA immune complexes, that's fundamental to understanding everything else about it.
And like we just said, this primarily affects children.
Yeah.
While adults can get it, the picture your notes paint is definitely, centered around pediatric cases. That definition also immediately brings in the classic tetrad of symptoms. These are the four hallmarks you mentioned.
Yeah.
You've got palpable skin purpura that's a rash you can actually feel, often described as bruise-like.
Mm-hmm.
Then arthritis or joint pain, abdominal pain, which the notes mentioned can include significant GI bleeding, and renal involvement, meaning the kidneys are affected.
That tetrad is key.
Absolutely. So if you're seeing a child with these symptoms, or maybe a combination of them, that classic tetrad should immediately make you think of HSP, according to the material here. It's your sort of major signpost.
Okay, so moving from what it is to why it happens, the notes talk about etiology, the causes and triggers. Your notes state pretty clearly that the exact cause is, well, uncertain. Yeah, it's not fully pinned down. However, the material points to it likely involving an abnormal immune response, and this immune response seems to get triggered by various factors.
And your notes give us some really concrete examples of those triggers. Upper respiratory tract infections are common, definitely, but also medications, vaccinations, even insect bites are listed. These are the kinds of things that might, come before the HSP symptoms start.
Environmental, genetic, and other immune factors are also noted as contributors. It's likely a mix. Your notes even list a whole range of specific infections associated with recent illness. In these cases, things like Strep, Mycoplasma, EBV, Coxsackie virus.
Yeah. A lot of viruses and bacteria. Hepatitis A, B, Parvovirus B19, Campylobacter, Varicella, Adenoviruses. It's quite the list.
It is. It really underscores that frequent link to a prior infection, especially in kids. But here's where it gets really interesting, I think, especially when you consider adults. Your notes mention less common triggers. Things like vaccination, sure, but also malignancy, particularly solid tumors in adult males.
Wow. Okay, so it's not just about infections then.
No, not exclusively, though infection seems to be the main driver, especially in the typical pediatric cases. The underlying mechanism, though, tying back to the definition, is those IgA immune complexes we talked about. They deposit in the small blood vessels. Your notes specify where: the skin, the joints, the kidneys, and the GI tract.
Got it. So that mechanism explains why it's called an IgA vasculitis and why you get symptoms in those specific places. Okay, so who is most likely to get this, based on your notes? The risk factors seem quite clear. Age is the big one. Most common in children aged 2 to 11 years old, that's the peak range, and gender. The notes indicate a slight male predominance, just slightly more common in boys.
Right.
So again, while it can happen at any age, if you're revising, picture a child in that 2-11 age bracket that's the group most often affected according to this material.
Okay, let's delve a little deeper into the pathophysiology, connecting the mechanism to the actual symptoms people get. We've established those IgA immune complexes deposit in the small vessels of the skin, joints, GI tract, and kidneys.
Right.
So what happens then? What's the consequence? Your notes explain that these complexes, they activate the complement system, that's another part of the immune response, and they attract inflammatory cells. All this leads to inflammation of the vessel walls, making them leaky. You get increased vascular permeability, and that causes tissue damage in those areas.
Ah, okay. So the leaky vessels are why you see blood leaking into the skin, the purpura, or into the gut, causing the GI bleeding.
Exactly. And the inflammation and damage are why you get the joint pain or the kidney issues. It all links back to that initial IgA deposition and the subsequent inflammation cascade.
Okay, that makes sense. So you've got a child, maybe fits the age profile, has some of those classic symptoms, especially the rash. But what else could it be? What are the crucial things your notes say you need to consider to rule out? This is the differential diagnosis section.
Yeah, this is really important. Your notes provide a vital list here. First up, and this is critical, is intussusception. That's where part of the intestine telescopes into another part.
Right, like a bowel obstruction.
Precisely. And it's critical because your notes state it can not only look like HSP abdominal pain, but can actually occur as a complication in HSP patients themselves. It's noted in about 3–4% of cases.
So it's both a differential and a potential problem within HSP itself. That's tricky.
It is, so you have to keep it in mind. You also need to consider connective tissue diseases like SLE, systemic lupus erythematosus. This is why, as we'll see later, an autoantibody screen is listed under investigations to help differentiate. Other causes of a purpuric rash are absolutely essential to rule out. Particularly serious ones like thrombocytopenia, low platelets causing bruising, or even meningococcal meningitis. These need urgent consideration, obviously.
Definitely.
The notes also list other causes of glomerulonephritis, that's inflammation in the kidneys filters, if the renal symptoms are really prominent.
Right, if kidney issues are the main thing you're seeing.
Exactly. And other potential sources of severe abdominal pain, like inflammatory bowel disease.
Okay.
And finally, your notes mention a specific condition called acute hemorrhagic edema of infancy. Key features described are, it's self-limiting, you get fever, swelling, edema, and a characteristic rosette-shaped purpura, often on the face, ears, and extremities.
Ah, so the location and shape of the rash are different. That helps distinguish it. HSP rash is usually lower limbs, right?
Classically, yes. Lower limbs and buttocks, so that distribution is a key differentiator.
Let's put this in context with some numbers. What about the epidemiology, particularly in the UK, as noted in your source?
Sure. Your notes confirm this is the most common systemic vasculitis seen in children. That's a big statement.
Yeah. Number one.
The peak prevalence is specifically between ages 4 and 6. It's noted as rare in very young infants, under 1 or 2.
Got it.
Your notes give the incidence as roughly 10–20 cases per 100,000 children per year. And the UK annual incidence overall is about 620 per 100,000 population. So not super common, but common enough that you'll encounter it.
The notes also mention higher incidence in Caucasians, and interestingly, a distinct seasonal variation. It's more prevalent in winter and spring. Why might that be? Well, it ties back to what you said about etiology, that strong link with upper respiratory tract infection.
Exactly. Those URTIs are more common in winter and spring. It fits the pattern.
Makes sense.
And while it's primarily pediatric, your notes do highlight that occasional cases occur in adolescents and adults. But often, and this is important, with increased severity and, crucially, more frequent and severe renal issues. So age really does seem to change the potential clinical picture and the risk profile.
Right. So how does this condition typically present? What would you actually see based on your notes when a patient develops HSP symptoms? The clinical presentation.
Well, as we touched on, your notes say it often starts with an upper respiratory tract infection in the preceding weeks. That's a common history.
Okay, so a kid had a cold a couple of weeks ago.
Potentially, yes. Then the classic symptoms start. The rash is usually the most visible sign, that palpable purpura, those raised bruise-like lesions. A really helpful memory tip from your notes is that this rash classically appears on the lower extremities, legs, and buttocks, though it can spread sometimes. Seeing that distribution is a major clue.
Lower limbs, got it. What about the joints?
For the joints, you'll typically see pain and swelling, often affecting the larger joints like the knees and ankles. Makes it hard for them to walk sometimes.
Ouch. And abdominal symptoms?
Common. Pain, nausea, vomiting, diarrhea. Your notes specifically highlight the possibility of bloody diarrhea, which indicates GI bleeding. That's a significant finding.
Definitely. And the renal side.
Renal involvement shows up as blood in the urine, either microscopic or visible. That's hematuria, and protein in the urine, proteinuria. You pick these up on urinalysis.
Okay.
Your notes also list other possible, though maybe less common, symptoms like a low-grade fever, just feeling generally unwell. And they also point out some specific rarer presentations that are clinically really important to recognize. Things like scrotal involvement swelling and pain, which can look very much like testicular torsion.
Oh, right. That needs urgent attention.
Absolutely. Needs urgent investigation, usually an ultrasound. And then there are rare neurological symptoms mentioned, like headaches or even seizures. Much less common, but possible.
So, circling back to that core concept, the notes really hammer home the classic tetrad. Palpable purpura, classically lower limbs, joint pain, GI symptoms including potential bleeding, and renal involvement, haematuria, proteinuria.
Exactly. And the diagnostic criteria listed in your notes from Euler-Printopres, they formalize this. They require having that palpable purpura plus at least one of the other key features. So abdominal pain or typical findings on a biopsy if one is done, or arthritis, arthralgia, or evidence of renal involvement like haematuria or proteinuria.
Okay, so the diagnosis seems to be based on fitting those clinical criteria.
Primarily, yes.
Which raises an important question. If it's clinical, what actual test do you do? What are the investigations for?
This is a really crucial point from your notes for revision. The diagnosis is primarily clinical. There is no single definitive lab test that confirms HSP. You piece it together using the clinical picture and those criteria.
Right, so no HSP blood test.
No, unfortunately not. So while there isn't a single diagnostic test for HSP, the investigations listed in your notes are vital for assessing, well, how severe it is, checking for organ involvement, especially the kidneys, and importantly, ruling out those other conditions from your differential diagnosis list.
Okay, so what tests are listed?
Urinalysis is essential. You absolutely need to check for hematuria and proteinuria, those signs of kidney involvement. That's probably the most critical baseline test.
Makes sense.
A full blood count, FBC, is done. Your notes say it might show an elevated white count or eosinophilia. Platelets are usually normal or even increased, and checking the platelet count is key to help rule out thrombocytopenia, which is a different cause of purpura.
Got it. What else?
ESR, the erythrocyte sedimentation rate. It's a general marker of inflammation, and your notes say it's often elevated in HSP. Not specific, but gives an idea of inflammation level.
Okay.
Serum creatinine is checked, particularly if there are signs of renal involvement on the urinalysis, to assess kidney function directly.
Right, how well the kidneys are working.
Exactly. Serum IgA levels might be measured. Your notes state they are often increased in HSP, but this is a really important nuance. They are not diagnostic. You can have HSP with normal IgA, and elevated IgA doesn't automatically mean HSP.
Okay, so helpful is elevated, but not definitive.
Precisely. An autoantibody screen is listed specifically to help rule out those connective tissue diseases, like SLE, that were in your differential diagnosis.
Right, checking for lupus and similar conditions.
Yes. And if specific symptoms are prominent, your notes list imaging or procedures. An abdominal ultrasound or maybe even a barium enema might be needed for severe GI symptoms, especially to look for or even help treat that intussusception we talked about.
Okay.
A testicular ultrasound is necessary, if there's that scrotal involvement, to rule out torsion.
Urgent.
Very urgent. And a renal biopsy might be considered, but usually only if there's persistent or severe kidney disease, like nephrotic syndrome, to really assess the extent of the kidney damage.
Okay, so biopsy isn't routine, only for severe kidney issues.
Generally, yes. And there's one more specific note for older adults in your material. If HSP develops without a clear preceding infection, consider screening for an underlying malignancy. That reinforces that less common trigger we discussed earlier.
Right, the cancer link in adults.
Yeah.
Okay, so once you suspect or diagnose HSP based on these notes, what's the approach to management, specifically in the UK, as your notes indicate?
The core principle, according to your notes, is symptomatic treatment. The condition is, thankfully, largely self-limiting in most cases. It gets better on its own.
So supportive care mainly.
Primarily. Supportive care includes things like simple analgesics, paracetamol, maybe for the joint pain. For kidney involvement, supportive measures might involve just monitoring, ensuring good hydration. If there are skin lesions causing issues, basic wound care. NSAIDs, like ibuprofen, can be used for joint pain, but there's a very important caution mentioned.
What's that?
Use them carefully if there are already signs of renal issues or significant GI symptoms, because NSAIDs could potentially worsen kidney function or stomach irritation, so caution is advised there.
Good point. What about hospitalization?
Hospitalization is noted as necessary sometimes, mainly for monitoring severe cases, managing complications like significant GI bleeding, severe pain, or worsening kidney function.
Okay. And what about treatments aimed specifically at the kidney involvement? That seems like the biggest worry.
It is. And regarding treatment specifically for renal involvement, your notes explicitly state there is no consensus on routine treatment or prevention strategies, particularly in children.
No consensus. So what do they do?
Well, corticosteroids, like prednisolone, may help with symptoms. They can reduce joint pain or abdominal pain. But your notes say they are not routinely recommended for preventing or treating the kidney disease itself, based on the current evidence for kids. Close monitoring, usually guided by pediatric kidney specialists, nephrologists, is the standard approach mentioned. Watchful waiting, essentially, with support.
So steroids aren't standard for the kidneys in kids. What about other treatments?
Plasma exchange is listed as something considered for some adults with very severe vasculitis and nephritis, but your notes add the important caveat that more research is needed. It's definitely not standard treatment for most cases, especially not in children.
Okay, so the high-yield takeaway for management from your notes seems to be mostly supportive care, manage the symptoms, use caution with NSAIDs, and involve specialists if there's significant organ involvement, especially watching those kidneys closely.
That sums it up perfectly based on this material.
All right, let's look at the future then, the prognosis. What can you expect once someone has HSP based on these notes?
Okay, prognosis. The good news up front is that the vast majority of patients recover fully without long-term complications. The condition is generally self-limiting, resolving over weeks to maybe a few months.
That's reassuring.
It is. However, your notes point out that relapses can occur. About 1/3 of patients might experience a recurrence of symptoms.
Oh, okay, so it can come back.
It can, yes. And a really critical point for ensuring a good long-term prognosis, which is highlighted in your notes, is regular monitoring. Specifically, blood pressure checks and urinalysis. This is absolutely crucial because potential renal involvement can sometimes be delayed, or it can persist even after other symptoms go away. Catching it early is key.
So follow-up is essential even after they seem better.
Absolutely essential. The notes acknowledge that while most do well, some patients may experience recurrent episodes or, more worryingly, develop long-term complications, particularly chronic kidney disease. And that can, in some cases, progress over time.
Right, the kidney issue again.
Yes, and that leads us directly to the potential complications. The most common and the most significant major complication listed is, unsurprisingly, renal involvement.
How common did the notes say it was?
Your notes say up to 55% of children with HSP experience some degree of kidney involvement. Now, the severity is variable. It can range from just microscopic blood in the urine, which resolves, to more severe nephritis or nephrotic syndrome. Your notes reiterate that renal involvement generally has a worse prognosis in older children and adults compared to younger kids.
But end-stage kidney disease is rare.
Thankfully, yes. End-stage kidney disease requiring dialysis or transplant is noted as rare, occurring in less than 1% of cases overall.
Okay. What other complications are listed?
Your notes then list other potential complications, described as rare but serious things you need to be aware of. These include major GI bleeding, bowel infarction, where part of the bowel dies due to lack of blood supply.
Wow.
Intussusception, there it is again, confirming its place not just as a differential but as a complication. Testicular hemorrhage or torsion, linking back to that scrotal presentation we discussed, and even very rare neurological issues like intracranial hemorrhage or seizures. These aren't common at all, but they are listed as possibilities to monitor for in severe cases.
Okay, so mostly rare, but potentially very serious.
Exactly. Recurrence is also technically listed here as a complication or at least an outcome, with up to 1/3 potentially having a relapse, often within the first 4-6 months. This just reinforces the need for that ongoing follow-up.
Yeah, it all comes back to monitoring, which
Yeah.
brings us back to that final point in the complications section and maybe the critical takeaway from this whole discussion. Regular follow-up and monitoring are crucial to catch potential long-term issues, especially related to the kidneys.
Absolutely. So, just to summarize the key insights from your notes on HSP, it's fundamentally an IgA-mediated vasculitis. It mainly affects children. You diagnose it clinically, thinking of that classic Tetrad, the palpable purpura, especially lower limbs, the joint pain, the abdominal issues, and the kidney involvement, check the urine. Management is primarily supportive, but vigilant monitoring, particularly of kidney function and blood pressure, is absolutely vital because while most kids recover fully, renal complications are the most significant long-term risk to watch out for.
That's a great summary. And thinking about that long-term risk, given the possibility of recurrence or kidney problems showing up later, especially as highlighted in your notes, what does the long-term follow-up picture really look like for someone diagnosed with HSP? How long should that monitoring actually continue? That's maybe a thought to carry with you as you process all this information from your notes. We really hope this deep dive has helped crystallize the key points from your notes on Henoch-Schönlein Purpura, making it clearer and hopefully more high yield for your revision.
Definitely. And to really embed this knowledge, going back over your own notes after this,
Oh,
maybe
yeah.
cross-referencing key points, that would be highly beneficial.
Absolutely. And if you are looking for ways to test your understanding or explore related topics further, especially if you're prepping for something like the MSRA exam, there are some great resources out there. You might want to check out places like passthemsra.com and freemsra.com. They offer materials that can really help you solidify these concepts. Thanks so much for joining us for this deep dive into your material today.
Yeah, keep up the great work with your learning, and all the best.